I'm Karl Mercieca. I work in Bonn, trained in the UK, Director of Glaucoma Services in Bonn for the last 3 years. And when I moved to Germany, quickly started adopting new MIGS devices. So before in the UK I was a stenting guy, and when I moved to Germany I got suddenly into canaloplasty. So the transition is actually not that big, because actually it's the same basic skills you acquire. We all start by learning cataract surgery, and those skills are then transferred into the more subtle skills of looking at the angle, operating on the angle. Perhaps you start with putting stents in the angle. Nowadays there are other devices, including this, which is actually more surgical than actually putting a stent in. So yes, I work for various companies, including loads of MIGS companies, so I have a lot of experience with all different devices. Next slide, please. So let's present a case, okay? So we have a 73 retired doctor. It's always nice to have some extra stress when you have an ex-colleague there. She's got asthma, high blood pressure, so she can't take a beta blocker, but she's been on 3 drops for the last 5 years. So 3 drops, has glaucoma, and as you can see, if you had a pressure of 22 in your left eye on 3 drops, if you have proper glaucoma, you wouldn't be too happy. She also has cataract, so she's over 70, and actually her vision is reduced. So this is the perfect mix for you, and by far the largest group of patients where I choose to do a combined phaco plus something else. So you can see that she's got large cups, but of course, is this glaucoma or not? Could this be a large disc? So if we go forward now, 1 slide. So I'm very keen on getting OCT scans these days, and not just looking at the RNFL, but also the posterior pole. We've got the hood reports now on various scan devices, and you can see how much glaucoma damage there is in this patient. So this is not an ocular hypertension. This is a patient with proper glaucoma. Of course, we rely also on the visual field. So when it comes to visual fields and your classical Hodapp-Anderson classification, this patient is a mild glaucoma. But if you look at the amount of damage structurally, you definitely want to do something. You would not lie with pressures of 20 with 3 drops in a relatively young patient. So the decision was made to do something. Why a phaco MIGS, and perhaps why a phaco iTrack? Well, we want to reduce the pressure. We also want to get her off drops. I do feel that anyone who's on more than 1 drop, it's suboptimal. More than 2 is substandard. So you really want to get people, if not off all drops, reduce their burden so they can remember to put them in, they put them in properly, they're more engaged in their treatment. You might not stop them off drops for the rest of their life, but it's a big advantage. So she's struggling to keep up with her drop regime. She feels her vision is deteriorating. She obviously has red eyes from all those drops. And she's also getting depressed about it. And this is something we sometimes we don't recognize. A lot of our glaucoma patients do get depressed. And this is something we miss because we don't have time to talk about and we don't have time to listen. So in this case, I went for a phaco iTrack. I work in a big teaching hospital. I have fellows now. In Germany, fellows are not as common as in the UK, where even one of my ex-fellows here is now a prolific surgeon back in Australia. But now I'm really glad to leave stuff like this, a phaco plus device which is easy to learn, safe, in the hands of my more junior colleagues, who of course have experience as well. In this case, my colleague chose a subtenons procedure, but I do a lot of these in topical. I do inject intracameral lignocaine though, so it's not just drops. I think intracameral lignocaine is the trick. As a day case procedure, of course, depending on the country you work in, there are debates as to what gets remunerated, what's funded, what's not. But on table, she also had a high blood pressure, which the anesthetist lowered. So she ended up being hypotensive on table. Surgery was uneventful, so uneventful phaco, uneventful iTrack. But on discharge, she was on her way home. She had a vasovagal attack and fell, came back, and of course I get called, oh, your patient's collapsed and now their eye is filled with blood and we think they've injured their eye. So I have a look, and actually no, it was just a small hyphema, which, again, if you're a canaloplasty person, you like, because hyphemas are quite common, they're normal. And all the big canaloplasty people will tell you a hyphema is a good prognostic sign. It means you've been in the right place and reflux is normal. But we kept the patient on the ward to make sure. This is the surgery. So Dr. Petrak, now he's a junior consultant colleague, fantastic surgeon. Again, I'm just showing you how easy this is. So Dr. Petrak had done a few trabectomes before I arrived in Bonn, but he quickly mastered all kinds of MIGS, including the iTrack. He still hasn't learned all the tricks I have given him. So for example, I prefer using diffuse illumination. He's on the red reflex, so he's just finished the phaco and he's forgotten to put the red reflex setting off. I strongly believe with diffuse illumination you can see the angle structures better. What's important is also where you put your paracentesis. So this is a device that you want to place about 3 clock hours from where you're entering, because you want to give yourself enough space to come around. So it's like hugging the angle, I call it. It's not like a device you're just shooting in. You have to have space and you have to give yourself space. If you use diffuse illumination but not on the brightest setting, you can see the LED going in without having to switch the light on and off, which sometimes can be quite disruptive. So in this case, I think even maybe he knew we were filming him. He wanted to have an effect and impact, which is quite cool to see the LED. And what I think is really great with iTrack Advance, or iTrack in general, of course, is the fact that you see where you are. So you can't lie to yourself or to anyone of where your probe is. And it's security for you. You know you've done a good job. You can't always go around, but most cases you do. And even if you don't go a whole 360, because you're clicking and injecting viscoelastic to large volumes, you can make sure that you are freeing up space in your Schlemm's canal, in your collector channels. So I think that this is a pretty easy thing to master. You know, if you're using MIGS devices already, switching to this is quite easy. Of course, people have been asking me, okay, tricks then to prevent the hyphema you mentioned. Make sure you remove the viscoelastic at the end of the procedure, but then the eye will be soft, heme will come out. So make sure you hydrate your wounds as well, because I think pressurizing the eye is so important to reduce the amount of hyphema. So another thing which I think is really important is expectations, patient expectations. The patient having the phaco iTrack will be sat next to a phaco patient. They both wake up the next day. The phaco patient is 6'6" already, and the iTrack might be 6'12". So if you tell them that their vision might be blurred for a few days, it's so important, because within a week, 2 weeks, they'll be seeing perfectly. But just make sure that they are aware that the vision might not be as good as a just standalone phaco the next day. In this case, it was 660, so who knows whether the fall affected the hyphema and there was more diffuse heme, etc. Pressure was 16 on 2 meds. Vision of 20/20 came later. But essentially, by the time the hyphema resolved after a week, I could stop the medications, and the vision by 4 weeks was 6/3. So that's, as we say in Germany, 200%, which is phenomenal. And the patient was so happy because, of course, they were seeing incredibly well and they were off drops. And now, of course, after summer, they wanted to go on holiday. He wanted to go on holiday with his wife, so we haven't done the right eye yet. So this is basically a classical case, easy case. It's nothing, you know, complex, but this is what you want in your practice. I mean, the complex cases are cool because they make you have to think out of the box, but you want patients to have a nice, safe, easy journey. Super busy slide, but this is just my thoughts of how we've evolved in our managing glaucoma, especially in the earlier stages. You can find this online probably somewhere in a publication, but essentially, if we think early enough in glaucoma now, especially in patients who are having a phaco, we can prevent them from needing bigger surgeries in the future. But not only that, even if they do need bigger surgeries in the future, by doing MIGS, we can actually also have better eyes to operate on with better results from drainage surgery later. And the good thing, again, of iTrack Advance, for example, is because it's canaloplasty, you're not putting any hardware in the eye, you're preserving tissue, you're not cutting tissue. So theoretically, you could even do a second MIGS device later before then going over to the more invasive bleb-forming procedures. I think we'll go to the next case. Mary, my colleague from the States, can, of course, introduce herself, but it's a great honor to be sharing this with you, and I'm excited to see your case, Mary.
Thank you so much. That was so great to hear from you about your case and how you chose the iTrack Advanced procedure for your patient. My name's Mary Qiu, and as of this week, I'm a glaucoma specialist at the Cleveland Clinic, where I did my glaucoma fellowship training about 6 years ago. I was practicing as a glaucoma specialist at the University of Chicago for the past 5 years, and so all the cases I'll be showing you today are from my practice in University of Chicago. So the first case that I'm going to show you is a case of a 360-degree canaloplasty. It was combined with phaco, and it was done by my my PGY4 resident, Jessie Wang. So she's in her last year of residency training, and she is currently a glaucoma fellow at Duke. And the residents with me had the opportunity to do a lot of MIGS procedures, including iTrack Advance, and I just wanted to demonstrate how easy this was to do even by a trainee in their residency. Just as an introduction to the video itself, I do my MIGS before the phaco, and I prefer that when I'm teaching residents or if you're a novice starting off with MIGS, because when you do it before the phaco, the cornea is perfectly clear, you don't have any edema at the wound, maybe after a tough phaco. I actually like to use Helon 5 in my anterior chamber when I do the MIGS before phaco with my trainees, because the Helon 5 is so heavy that it really fills up the AC, the cornea won't have any striae, the angle will not have any reflux heme, and no viscoelastic will fall out of your wound. So it just makes a very beautiful setting for teaching a trainee how to do their first MIGS. And so I like that just for teaching purposes. I also like to use Trypan Blue for all of my MIGS when I'm teaching residents, and so you'll notice that the TM is stained blue, and it just helps them to find the target for where to aim their instruments. In this video, when it begins, there's already a main wound that's made temporally, which is where I'm sitting, and then you'll see that extra paracentesis for the iTrack Advance, which is a few millimeters off to the side, and it's pointing directly to the nasal angle. So that paracentesis is not pointing radially like a regular para, it's pointing at the nasal angle. So you can play the video now. So I like to make the incision with a Sinskey hook when I'm teaching trainees for the first time. That way they don't have to really worry about getting it started. There's already a hole there, but you can actually just use the iTrack Advance metal injector to begin. But this is just all the training wheels for my trainees I like to use when I'm first teaching them. So you'll notice Jessie has put her iTrack Advance injector and seated the metal injector into the Schlemm's canal. She's pressing on the blue slider and the catheter came out, and you could see the blinking red light come out. So now you might notice she's drifting a little bit with her gonioprism because she's probably paying so much attention to her right hand that she's not so focused on where her left hand is going. But it's okay. The right hand has not moved very far. The catheter has not pulled into the TM and has not caused much of a goniotomy. You see the light coming around here. She's probably looking for the light because I'm telling her, do you see the light? Do you see the light? So she saw the light go around, then she saw the light go back. And that was it. It was so quick I couldn't even finish talking. So as she was advancing the catheter forwards, I actually like to start clicking the catheter. Typically, when we perform the canaloplasty, we perform the canaloplasty on the way out. So you would advance the catheter all the way around, and then as you withdraw the catheter, you would click about 10 clicks for every quadrant, so about 40 total clicks for the entire circle. I actually modify this slightly when I do my canaloplasty pre-phaco under Helon 5, because the Helon 5 is so heavy that the Schlemm's canal is smushed, and so if you try to advance the catheter, there's kind of a bit of resistance. So I like to advance about 20 clicks on the way in, and then 20 clicks on the way out. That way the viscoelastic can help lubricate the canal and make a little space as I'm pushing my catheter through the canal, and there's Helon 5 on the other side. You would not need to do this if you had regular viscoat or even regular Helon in the anterior chamber. This is just one of my modifications. So for that case, I'm doing the clicking, and she's the primary surgeon, but if you did not have an assistant, your scrub tech would be clicking for you. And you should tell them when to click, because they don't necessarily see how fast the red light is moving. So if they're just clicking indiscriminately, you could quickly click too much or in the wrong place. So you should be counting 1, 2, 3, 4, 5, and on to 10, and then they would click with you, and just repeat that every quadrant, or just count to 40 or something. But you must indicate when to click, because otherwise your assistant may not know. So for this next case, this is a case that I'm the primary surgeon on, and this eye is already pseudophakic. So this case, I added a 90-degree goniotomy in addition to the 360-degree canaloplasty. Because this case, unlike the previous case, they were already pseudophakic, so it's not like they were already going to the operating room for phaco. This procedure is solely for pressure lowering, and they did not just have mild glaucoma, they had more moderate to severe glaucoma. So in the United States, iTrack is indicated for use for canaloplasty or goniotomy, and not both at the same time, but you can only bill for one. But sometimes I do like to combine the two procedures, and I can titrate how much canaloplasty do I want to do, which is always 360 pretty much, and how much goniotomy do I want to do, which can range from 90 to 180 to 360 degrees. So in this case, I actually wanted to do the goniotomy with the iTrack Advance, and this was my first time trying to do the goniotomy with the iTrack Advance, and so the reason I ended up using a Sinskey was I was just doing this for the very first time and I couldn't quite get it, so then I switched to the Sinskey and just kind of made it bigger. So I'll show you my attempt to do it, and then on the next video I'll show you actually doing it. So you can play the video. So this eye is already pseudophakic. There is no main wound. There's only a paracentesis off to the side, and it's pointed to the nasal angle, and I even sort of swing it over to the side a little bit to make it so that the iTrack Advance injector can very ergonomically reach the nasal angle. And this is Helon, regular Helon in the anterior chamber now, not Helon 5. I use the tip of the injector to make my initial scratch. I seat it in the back wall of Schlemm's. You see the light coming out. I'm not sure if it's in the right place, so I pull it out and push it back in. It is in the right place. I see the light. And as the light falls off of the edge of your gonio prism, this is normally where you would lose view of anything you were putting in Schlemm's canal that were going that far. But here you don't lose the view. You see the bright blinking light. It's coming all the way around. And you even see some blanching of the episcleral vessels temporally, sub-incisionally, but there's no incision there. The light's all the way around now. Focus on the temporal vessels. I'm changing the focus of my microscope to really highlight the blanching, because I knew I was recording this video, so I said, hold on, let me record the blanching. It's going to look beautiful, and it does. So now the light's all the way around, and now I'm clicking 20 times on the way back as well. So I did 20 on the way in, 20 on the way out. You can see the light coming back around, and then all the way back to the nasal angle where I begun. And here I'm trying to tear a little bit of the TM to create a goniotomy, and it doesn't really tear all the way. The catheter just comes out. This is because I did not leave a very long length of catheter in the canal when I started tearing. I should have left it longer. So I just used a Sinskey hook and decide to do a goniotomy with this. And as you'll notice, there is zero blood reflux. This is because I have already performed a canaloplasty 360. Schlemm's is full of visco, and the downstream collector channels are full of visco. So as I do this move, there is zero blood. And this would be the case as well if I performed the goniotomy with the iTrack itself. I think one of the reasons that the iTrack catheter was able to just kind of come out of the canal instead of performing the goniotomy when I had such a short length of it in there was because it's actually relatively soft and flexible, which I like. The iTrack Advance is not very rigid, so it's a little bit less likely, I think, to bluntly dissect its way into the suprachoroidal space, for example. Though, if it did end up in the suprachoroidal space, which does happen, the blinking red light will disappear. So you will know immediately that the catheter is no longer in Schlemm's and you should stop advancing it forward. So the blinking red light really can save you if the catheter has a mind of its own and is trying to go somewhere unusual. But luckily the catheter is very soft, and so it is hopefully not as damaging if it were to find a wrong track, and you could immediately pull it back to right your course. So this final case that I'm going to show you is a pseudophakic eye that has a more severe disease. I believe this particular case was steroid-induced glaucoma. For example, an eye that's receiving intravitreal steroid injections, for example, for like a retinal pathology. And so in this type of indication, the blockage is mostly at the trabecular meshwork. So anything we can do to treat the angle and put a cut in the trabecular meshwork will help the aqueous flow out the physiologic outflow pathway properly. So I had intended to do a 360-degree trabeculotomy. And this might be historically called the GATT procedure or something to that effect, where you would pass the catheter all the way around in a circle and then retrieve the tip of the catheter and then pull both ends, and this would cut the TM all the way around. In this case though, I hit an obstruction while I was trying to advance the catheter. And so this video is going to demonstrate the blinking light and how helpful it was to show me where is the obstruction. And I kept trying and I couldn't get past it, and so this told me, okay, I'm going to back up and try the other way. And when I went the other way, I hit an obstruction as well, and then I was able to just do the goniotomy 1/2 at a time, which is something that you can do very versatilely with this iTrack Advance. If you were to face an unexpected situation intraoperatively, you can adapt because the instrument is very adaptive. So I just wanted to give you that introduction before I show the video. So you can play the video next. So again, this eye is already pseudophakic. I'm again starting with the Sinskey cut just to make it easier for my resident to begin. So this is a PGY4 resident again. This is under Helon, not Helon 5. I just do the Helon 5 when it's combined with phaco. Again, her prism is drifting a little bit. She puts the tip right in there, the catheter comes out, you see the bling in that area. And this is a moment where you don't want to keep injecting because your catheter is stuck. You see the light is still blinking. In this case, you can back it out a little, inject some more visco, but it still doesn't want to pass. I think it's actually hitting a collector channel orifice as opposed to just a narrow spot in Schlemm's. Because if it's just a narrow spot in Schlemm's, you can usually kind of power through it with more viscoelastic. But if your catheter is hitting a circle of the orifice of collector channel, you're not going to be able to go past that. And so I switch with her, I try, I get stuck in the exact same location. This is just a patient anatomy issue. So we decided to take it out. I flip the thing over by just twisting the nozzle. My handpiece is still on the same location. I twist the nozzle to the other side and I go back in. And the light comes around and it actually gets stuck right around over here. And so now it's getting past the very first stuck point because the orifice is facing the other way, but it gets stuck on a different collector channel orifice this way. So I say, okay, let me take what I can. So I performed a goniotomy on that side, and then I flip it back around, and I say, let me go back to the first side and see if I can just do a goniotomy with the iTrack catheter the first way. And I do. So this time you see I left more length of the catheter tip is all the way here. This way when you start to pull it out, there's enough friction keeping it in the canal so that you can perform that trabecular meshwork cutting procedure. So this patient did extremely well. In cases like secondary open-angle glaucoma, such as steroid response or pseudoexfoliation, pigmentary, these types of cases, they can respond really well to angle procedures, especially with a little bit of extra goniotomy, and these eyes can often be spared a trab or tube if you can successfully perform one of these angle procedures. That these 3 videos really showcase the versatile range of the iTrack advanced catheter. You can use it for mild POAG and just perform a canaloplasty at the time of phaco. You can use it for moderate to severe POAG, even in pseudophakic eyes, even if you want to add a little bit of extra goniotomy, either with the catheter itself or with an extra instrument like the Sinski, or you can do a 360-degree trabeculotomy if it's indicated where you practice. And so it's just an extremely versatile instrument. The blinking red light shows you when you're in the right place, and it shows you when you're in the wrong place, and it helps you redirect as soon as you need to. The viscoelastic can be injected on the way in or on the way out, as much or as little as you want, so it's very titratable, and I like to use this a lot in all types of my patients. I just wanted to stop for a moment here to talk about which viscoelastic do I use. So when combined with phaco, I personally put Helon 5 in the anterior chamber for teaching purposes. You can really just use Viscoat or Helon or something. But the heavier one you use, the less blood reflux, and the lighter one you use, a little bit more blood will come in. So I second what you said about maintaining the pressure in the chamber, making sure you hydrate your wounds. I like to have a syringe with BSS coming into my para as I pull out with the IA, so that there's not any reflux bleeding when I do any MIGS at the end of the case. Or if it's standalone, I still try to inject some liquid in as I come out with like an IA or something. When it's standalone in a pseudophakic eye or standalone in a phakic eye, I like to use Helon in the anterior chamber because Helon 5, you need to use IA to rinse out. But regular Helon, I just use BSS on a cannula and just rinse it out through a para. So I do not open irrigation, the irrigation aspiration handpiece when I do a standalone case. Sometimes if it's standalone in a phakic eye and they're like very young and I'm worried I'm going to cause a cataract or something, sometimes I'll use Helon 5 anyway and then rinse it out just for safety. I want to point out that in the catheter itself, you want to hook that up to Helon. You do not want to use Helon GV or Helon 5 or anything very heavy. The catheter itself should be primed with Helon because that's what you want going to Schlemm's canal. That's going to go through the canal and slide forward into the canal as opposed to dissecting into any other spaces. So make sure you use Helon or something less heavy than Helon in the catheter itself. This next slide is just a bunch of pictures of me and my residents at University of Chicago performing iTrack Advance as their primary surgeon. This gentleman here has performed 60 MIGS procedures as a resident and is going to be a comprehensive ophthalmologist in Northeast Ohio. And this is Jessie. She's a glaucoma fellow at Duke right now. That gentleman's going into comprehensive next year, and she's choosing pediatrics, but she did a great job in the angle as well and actually performed an iTrack canaloplasty. So I'm very proud of my former residents in University of Chicago, and I'm looking forward to teaching the new residents at Cleveland Clinic. Thank you so much for your attention, and I'm happy to take any questions.
I have a question actually.
Yeah.
You also sutured the wounds in a couple of videos, right? I think that's just extra precaution. Do you do that regularly or?
So that's just extra precaution. Sometimes if there's a patient that I feel like might be at extra risk of having some posterior pressure or floppy iris or just any kind of extra risk for anything funky going on with the wounds, I have a very low threshold to just place a suture. I use Vicryl because then it just dissolves and I don't have to remove it at the slit lamp. And I was actually going to say, as an extra tip, if you have a patient that you've done like a large goniotomy and you're worried about reflux bleeding, sometimes I actually pre-place a suture in my main wound before I IA the viscoelastic and come out. So sometimes I'll take a Vicryl, throw it in the main and tie like a 3, but then leave it loose, and then put my IA in, and then as I come out, I like fill BSS through the para, and then I quickly tie off the 3 and then 1-1. So maintaining your anterior chamber is so important for some of these reflux bleeding situations.
Yeah. Everyone asks reflux bleeding, and of course, yes, I don't mind it, but if you could prevent it, because you know you're in the right place, and that's a great thing with the LED, as you've shown there. You know where you are. So reflux bleeding, if you can prevent it, would be ideal, wouldn't it? So I really like the way you handle your training. In Germany, residents don't get much surgery, so I miss that, and it's really nice what you're doing, even just starting the incision for them and stuff like that, which is really cool. But I think it shows also that iTrack is actually not that difficult to master. I think it's just like training phaco. You start with certain steps, you make things easier by staining the capsule in terms of phaco. In this case, you're staining the TM. I suppose even when I start training, even junior fellows, it's finding the right patients, open angles, trabecular meshwork that's pigmented that you can actually spot and identify. These are all little things when you're starting off with. So when you're starting off with iTrack or any MIGS, don't choose the difficult cases, go for the open angles, pigmented, use stripe and blue. I think that's a fantastic idea.
Thank you. And you also mentioned making sure that what type of block do you use with lidocaine and everything. I will actually add a subtenon's block or even a retrobulbar block sometimes. That's actually how I learned my phaco MIGS when I was a fellow. We just retrobulbar blocked everybody. And so as an attending, I retrobulbar block a lot of these eyes, unless they're on blood thinners, in which case I don't. If they're monocular, I don't. If they have a long axial length, I don't. But any other regular run-of-the-mill eye, I just do a retrobulbar block, and that has been safe. I've had no complications from the block. And I just like to do that if I'm teaching a resident for the first time and they're not so comfortable in the angle yet. It's just nice to really freeze that eye. But even a subtenon's block will be fine as well. So on those eyes that are on blood thinners or are monocular or have a long axial length, I subtenon's block them. And it just adds like 30 seconds to your procedure beforehand. And it just lowers a little bit of your own nervousness if you're learning a new procedure or working in the angle you've not done it before. I recommend just starting with a block and some trypan and a little of these extra training wheels.
Yeah. You go in and you get some bleeding. Could be from reflux, it could be actually you've gone a bit too deep, etc. You can't see properly. The tricks are you inject more helon, etc. You try and free up. You can move a bit further down, but you still can't see. Any tips?
Well, sometimes if you have a lot of bleeding and you don't have an extra wound, because if you have an extra wound, you just go in the extra wound and inject helon. Keep in mind that you have a catheter inside the eye, and the catheter has a lumen that helon comes out of. So sometimes if you need to push helon into the eye to get blood out of the way, you can actually just retract your catheter back and then point your catheter to where the blood is and have your nurse click the visco injector, and then the helon will come out of the catheter and push the helon away. So that's kind of a neat trick that you can do with iTrack because you have the ability to customize when you do the clicks.
Yeah, a really good, smart one. And I agree with you as well about actually injecting going in. Nowadays it's just standard because I think it really makes sense dilating as you go in as well, irrespective of whether you think or not there are some obstructions.
Yeah.
So I think that's a really important thing.